hope you can see my screen. Okay, so welcome everybody. The session now is about running functional mapping procedures in real time with high gamma and ultra high gamma. So basically we're diving into the cortiQ and go through the steps that are necessary to actually conduct functional brain mapping. So what is functional brain mapping? Just to give you a brief instruction. It's basically to delineate physiological or functional areas, also called the eloquent cortex in the gray matter, from the pathological tissue like brain tumors or epilepsy. And for that, several tasks, paradigms, protocol can be used with different modalities to understand where, for example, the motor areas are located, the somatosense areas are located, language areas are located, visual cortices for lower and higher visual categorization, memorization, and of course also planning regions and others. So which techniques can we utilize? Basically, we can categorize into observational, inhibitory, and excitatory techniques. So observational techniques are well known in neuroscience research because of the non-invasive fMRI studies. So many studies are actually conducted in an MRI scanner, where of course we can obtain the T1 weighted anatomical structures, fiber tracts with DTI, and then also the blood oxygen level dependency. So the deoxygenized hemoglobin in the blood, which tells us about how active a brain region is where the blood flows. And with that we understand which parts in the area or in the brain are actually related to a task compared to a resting condition. And this is a hemodynamic marker, but it's also possible to utilize it with an electrophysiological marker, for example with MEG, EEG, or electrocorticography or stereo-EEG. So all these are measuring voltage signals from the brain waves, and with that we get a biomarker for changes in the brain that are, for example, task related, similar to the fMRI. And the high gamma mapping also falls into this region of the electrophysiological marker, and I will explain that how that actually works. In contrast, we have the inhibitory and excitatory techniques. And it's important to understand that here we will, for example, mimic a lesion by deactivating parts of the brain with some interaction. So for example, with an electrical current flow, we can interrupt language or speech, or with transcranial magnetic stimulation, we can achieve similar effects, or when we sedate one hemisphere with an anesthetic drug, like in the WADA test, then we can also observe, for example, memory or language disturbances if the dominant side is affected. Also, it can happen that the stimulation techniques excite parts of the network, and with that show us, for example, if some brain regions are sufficient, for example, to contract a muscle. So you can already see to mimic a lesion is a very powerful tool for surgical decision making. So for example, inside the operating room, when you cause a speech arrest with the electrical stimulation, you know that you cannot cut that tissue, otherwise you will have a dysfunction or a functional symptom or deficit afterwards. In contrast, the observational techniques always are relying on a task-related differential map or contrast. So that means depending on how you choose your rest or baseline condition, you will get a very strong contrast of many different regions, or you get a very tiny contrast if the difference between the baseline and active condition is very tiny. So you really have to pinpoint what you actually want to observe to make a decision and contribute to the functional mapping. So let's have a better understanding of how the bold response looks like. So for an fMRI protocol, usually you have a block design rest and task pair. So one block could, for example, last around 20 seconds, and then you repeat it 3 to 5 times, and then you can understand where, for example, this significant changes in the scans based on a t-value for each voxel are located, and then you can make a functional category based on the contrast between rest and movement here. So that is related to the hand motor cortex, and we can see that here. So the signal changes of the bolt are usually between like 0.5 to 5%. That means that the SNR is a bit low, and it really depends on the proper statistical analysis and sufficient amount of data to make a valid result. Also, of course, the scanner is expensive, but on the other hand, it's giving us unlimited access to the brain tissue. It's non-invasive, so we can also do it for neuroscience research for many different questions. And also, it's good for pre-surgical planning to combine it with other modalities. Also, another limiting use case is that you have not like a free palette of paradigms. So of course you can talk or do some visual perception with a mirror, for example, but it's also difficult to do free movement tasks or in general do long paradigms in the scanner because it's a bit inconvenient. In contrast, when we look at the electrophysiological mapping, then we can measure directly from the brain. Here with this implanted electrode grids or with the stereo-EEG shaft, and by that we get the possibility to measure also changes in the brain that are in higher frequencies, for example, like high gamma frequencies. And with that we get a marker for brain activation, so the high gamma frequencies are actually reflecting neural activity underneath the electrode in the tissue. And when we now calculate that as a biomarker, then we can see that for different conditions, like here in this motor electrode location, we can see that here there's a baseline task where we are pretty silent, and then the patient tries to solve a Rubik's Cube. And with that we can see that the biomarker starts to really jump and gets active. Then after the patient stops the movement, the biomarker gets silent again. This is another task where we have a small burst but then get silent. This task is completely silent and again completely silent. So you see that the biomarker is very specific, and also the relative power change here is up to 500% or even higher. So compared to the bolt response, the signal to noise ratio is much higher, and also the temporal resolution, so the changes in the signal are very fast, like in a milliseconds range, compared to the bolt response that also depends on perfusion, and by that is a bit delayed and has a slower change rate. So how can we now better understand this high gamma activity? So we have to measure a signal directly from the brain, and we get the voltage trace that is digitized by the amplifier. And then we see here the power spectrum. And there's a resting power spectrum, so we can see this brain signal during rest. And then when we look at the power spectrum, we see this 1/f curve. There's also, like for the mains frequency, a peak. So this is called interference. And we can see that in the US at 60 Hertz and in Europe at 50 Hertz. And then we can see also here some oscillatory effects. So these are rhythms in the brain. And then when the person performs a hand movement task, then at the time of the movement, we can see that this signal changes, and in the spectrum we can actually see that the whole power spectrum is lifted. So when we now overlap that, then we observe after the mains frequency usually, so beyond 60 Hertz, we observe this broadband lift of the power. So this, when we can calculate it as a band power, for example, between here 60 to 100 Hertz, or for example up to 150 Hertz, then we can extract this as a biomarker for brain activity or a high gamma activity. On the other hand, we also see during the movement a suppression of low frequency bands, and that is also visible in the scalp EEG, for example, in the mu band. And interestingly, this is more widely spread, but when we look at the high gamma biomarker, then we can see that this is also very focal. So with that, we can even distinguish individual finger movements from one electrode to the other. So now when we ask the patient to perform a series of tasks, like here, stick out the tongue, listen to a task and solve a Rubik's Cube, then we can get differential maps for 3 different conditions. So here you can see the cue or the patient screen with the instructions. This is the patient waiting now for the instruction to stick out the tongue. And then we can see there's a lot of activation on the ventral temporal cortex, which actually is related to the visual processing of the task instruction with the picture. And then we have activation in the anterior temporal tip, which is some kind of semantic hub, and often also shown for the tongue area. And then we have also on the primary motor cortex the activation of the tongue. Then the patient listens to a task, and we get the activation. Of course, we begin on the visual cortex to perceive the instruction, and then on the superior temporal gyrus, the activation of the auditory perception. So here we can see the incoming raw data that is processed then in real time. Now the patient got the instruction to solve Rubik's Cube. So again, we have some visual processing, and then we can see that there is an activation here with the red bubble just superior to the yellow one, and the yellow one belongs to the tongue and the red one belongs to the fingers. So we can here nicely see the distribution of the homunculus along the motor cortex. And now we repeat that a second and a third time, just to be sure that the activation map is not relying on any statistical outlier. So the minimum time that we need to conduct the mapping is 12 seconds of rest and 12 seconds of active period. And then we can perform a valid statistical test. But of course, sometimes the patient is slow or not really performing the task nicely, or we are suffering from any artifact, and then we have to make sure that we have sufficient amount of data collected for reliable mapping. But we can already see that the activation maps barely change anymore after the first iteration. That means that the patient already did a very good job, and also that the signal quality is clean. So what steps do we need to do to extract the high gamma biomarker? So first of all, we need to get rid of the signal drift. So we need zero mean signals, and because of the DC coupled nature of the amplifier, we will apply a high pass filter to have signals with zero mean, and then see this common raw data visualization where we can see only the AC components, usually in frequency ranges from around 0.1, 0.5 or 1 Hertz up to mains frequency, or for intracranial EEG even higher. Sometimes we already also observe some disturbances. So for example, bad contacts are mostly indicated by a high impedance or by a strong interference of the mains frequency. So you will see the 50 and 60 Hertz mains frequency inside the signal, and that indicates that the electrode is not nicely attached to the tissue. And also in some cases, of course, we can see, for example, for the epilepsy monitoring, some interictal spikes during the mapping. In general, if these interictal spikes are equally distributed along the mapping in the baseline and task period, we will not have an effect that is kind of changing our mapping, but we have to understand that those signals exist. So usually for the bad contact channels, we will exclude them from the mapping because we don't want to spread, for example, this contamination into other channels with a common average reference filtering. The common average reference filtering is done to suppress the common mode signals that are not helpful for our analysis, and by that we simply subtract the mean of all the good channels from each channel and then get a very clean signal. So most of the mains interference will be diminished after the common average reference. And then we come to the feature extraction. So we will need to bandpass filter the signal and then create a band power value. So there are different ways to estimate the band power, like FFT, AR, variance estimation, and so on. Or we can simply, for example, square the signal and then downsample it. So there are various ways, and then we get a band power value, in our case a high gamma activity value. And so over the time we are collecting these values, and we have to, of course, make sure that these values are independent over the time. So they have to be sufficiently long. So usually the minimum should be 100 milliseconds. It preferable is 200 or 300 milliseconds to make distinct band power values that can be then accumulated into a statistical test. And then we can see here in red the distribution of the baseline condition, and in blue the distribution of the active condition. And we can already see that if we put the mean band power in the black line, that we see a lift of the band power, and based on the distribution this is significant. So we can say that this brain region here is actually related to the task. And then we need to visualize that properly to guide the operator of the mapping, and by that we are using coefficient of determination. So this R-squared value actually tells us the proportion of the variance that is due to the task. So for example, if we have an R-squared value of 0.5, then 50% of the signal variance are only caused by the task change. So of course, if you have 100%, then you have a step function. So this is physiological, not really meaningful. So we always have some noise inside the signal. So something between 0.1 and 0.5 is a very good response for an active region. And an R-squared value of 0.1 gets statistically significant for a mapping duration of 12 seconds or longer. There are already several outcome studies that show how effective the high gamma mapping is, and there are many centers, 2 centers, for example, in Detroit and also in Cincinnati, are mainly working on functional outcome studies, and they showed that, for example, a third of the deficits were predicted by the ECoG biomarker. So that means that after the surgery, there were still deficits remaining, although, for example, other mapping techniques like the fMRI or stimulation mapping have been conducted, and 1/3 of those deficits remaining were actually predicted by the ECoG biomarker in the high gamma frequency range. Also, it has been shown that if ECoG language locations are resected, that there is a decline in working memory score and language scores, also in visual naming scores, and the group in Portland with Barry Oaken and Ahmed Raslan showed that there's actually a significant longer overall survival rate for glioma resection when all these mapping modalities, including the high gamma mapping with cortiQ, are utilized for the guiding the surgery. And in total, we have now more than 8 independent institutes that reported that it's beneficial to use an ECoG biomarker for language and motor locations mapping. So how do we get that now into a clinic? So it has to be automated and quantitative. It has to be intuitive, used of course by a clinician and the team. It has to be portable, so for example, utilized at the bedside or inside the operating room for awake surgeries. It has to provide results immediately to make a decision, and it should not require complex co-registration, although of course we can do importing the MRI scan and CT scan to understand where the brain locations are. And that is all incorporated in the cortiQ mapping system. So that consists of a control computer with the actual mapping software on it, where we have this visualization of the activation map. It consists of a cortical stimulator to perform the standard stimulation mapping that has been used over many decades already. So for example, the Penfield method in the operating room. Then we have the amplifier that can record the high gamma activity with a high signal to noise ratio, the G-HIMP. Then we have a switching unit that is actually able to route between the stimulation path and the recording path. So we can then interactively with the brain map choose where to record from, and based on the recording activation stimulate into the target region where we, for example, want to understand if this causes then a speech arrest or aphasia after the stimulation. And this is now certified in Europe under the MDR. And of course, the high gamma mapping and the electrical stimulation with the eStim Pro also are FDA cleared already since many years. So which steps do we have to do now? The use cases are basically in a awake surgery. So for tumor removal, that would be a one-stage surgery where, for example, the tumor is likely located in an area that is necessary to preserve, for example, a language area. And then there is the decision to conduct an awake surgery. And in the awake surgery, we have to understand which tasks do we need to perform based on the location of the tumor or the lesion. And then when all is designed and the patient is able to perform the task, the craniotomy can start. And here we have the electrode implantation after removing, for example, the skull and opening the dura. And then we can place the electrodes and understand where in the brain the electrodes are located. And after the definition of the recording montage and everything is set up, the patient can get awake, and then we can perform the real-time mapping. So the high gamma mapping and also the stimulation mapping, we put all the results together and then confirm through the progress of the resection that the patient is able to perform the tasks. And then after the removal of the tissue, the patient can get into general anesthesia again. And then after the surgery, we can validate the surgical outcome. For epilepsy cases, usually we have the bedside case. So here we have first the non-invasive clinical examination where scalp EEG is utilized to roughly understand the epilepsy waveforms and their location, and then make an indication to implant the electrodes to more precisely localize the seizure onset zone. So we have a first surgery, the implantation stage, and then we perfectly know where our sensor locations are. And then during the epilepsy monitoring phase, we will understand where the epilepsy is located and can optimize the paradigms and the contrast for the mapping. And then we can actually conduct the mapping. So for the high gamma mapping, we can even do that in parallel to the monitoring. For the stimulation mapping, of course, we have to be careful if the patient is not taking anti-epileptic drugs, then we have to be careful with electrical current because it can induce a seizure. Sometimes this is even desired to better understand the epileptogenic region, but for the functional mapping, we don't want to have a seizure. And then there's the validation of the mapping results and the surgical planning, and the second stage surgery, which is the removal of the tissue, which in some cases can then again be an awake surgery case if needed. And then we have again the validation and outcome of the surgery. So let's have a deeper look into the individual steps. So as mentioned, we want to create the montage. So for example, in a stereo-EEG case for epilepsy monitoring, we can utilize the patient's MRI and by that superimpose or co-register it with a post-implantation CT. So in red you can see the artifacts that are visible in the CT scan, mainly from the cables and the metals of the electrodes. And the tissue is from a T1 weighted MRI scan and then segmented and created as a 3D map, cortex map in FreeSurfer. And now we can see here with the CT slices in red the artifacts of the electrode. So those are our electrode positions inside the brain. And now we can show that together with the brain hull or the dura. And here we can already see now in blue virtual stereo-EEG electrodes and in white the CT artifact. And now we can assign the stereo-EEG electrodes that we want to place over the CT artifacts, and based on the trajectory of the CT blobs and the location of the center of mass of each CT artifact, we can already anticipate the orientation and the location of the shaft. And then we can fine-tune it by replacing individual shafts. And also there's a snapping functionality to simplify the alignment of the electrodes onto the CT artifact. So we just have to touch the electrode artifact and the trajectory and then be able to align that to the CT. And then we can again fine-tune it and place the virtual electrode with the shape from a database that is actually from the electrode catalog from all the manufacturers that you may have. So for example, ECoG, PMT, Dixie, cortiQ, and so on. And by that we can then have this nice reconstruction. Of course, for the single stage surgery, like a brain tumor removal, we don't have the CT available. So we can work on a template brain. If we don't have the MRI available, we can again import the surface from the MRI by utilizing FreeSurfer or any other segmentation software. And then again we have the reconstructed brain, compute the brain hull or dura mater, so to say. And now when we are inside the operating room, we can actually make a photo of the open craniotomy with the electrodes and then align the brain with the photo. And it's possible to change the visual angle of the optics of the camera to fit the visual angle, the perspective on the photo. And then we can, based on the sulcus information and the location of the craniotomy, understand where the electrodes are located. So we can overlay the virtual electrodes at the actual location where it's implanted, and we can see the match with the photo. And now we know where our electrodes are located even during the single surgery based on a photograph. Then we need to create the paradigm. So for that we can utilize the paradigm or task creator. And we already have a palette of tasks, but it's also possible to create new ones. So here, this is, for example, a picture naming task where we have on the top like a movie clip where we can see the first baseline task, then the first active task, and then we can save that in a database of tasks and paradigms and preview them So here you can see in the center there is now a list of PNG files, so you can import the folder, for example with scrambled images here, and each image is shown for 1.6 seconds. You can show it also together with a jitter and shuffle them so that you don't have any anticipation effects of the patient for the perception. And you can define how many trials or events are presented in one block. And then you get also the stimulation trigger or presentation trigger for individual trials if you need that. And then we can create, for example, based on the baseline and active condition, this differential map. So we suppress the visual perception, but we want to understand, for example, for overt picture naming, the expressive language cortex. Or if we want to make the task more complex, we can also conduct a verb generation task. Then we need to go into the actual mapping and connect the patient to the amplifier, and then we can see the raw data that we are now measuring. And in this case, there are already some electrodes that are in bad contact. So based on the signal quality indicator, the yellow dot or the red dot, we can see that there is a high artifact or mains interference. After all the signals are in good shape, we can utilize those for the common average reference. Then we select a paradigm. So here now we have the retouchio paradigm, and you can see the box showing us that the first task is the kissing task, and we now can see the activation during the kissing. So first we have again the visual activation on the ventral temporal cortex, and then we can see that the strongest activation is actually on the motor cortex for the oral part, so on the inferior part of the homunculus. The next task is then the tongue movement task. So here again we have a resting condition in the tongue, so we can see that the tongue activation is now a bit stronger compared to the kiss activation, and also more focused. And again we have this activation on the anterior temporal tip. We can also change the visualization to stack the mapping layers or to visualize them in one map for each task, like we have seen that in the previous demo. And now you can see that for the Rubik's Cube, again, we have some visual activation and then the activation on the motor cortex. So now again, the Rubik's Cube activation is more superior compared to the tongue and the oral motor activation. Okay. And then after conducting the mapping 3 times, we get here this final activation map, and then we can actually create the results report. So we see when the mapping actually happened, which paradigm has been used, where the electrode locations are with the channel assignment, the activation for kiss, for tongue, for the Rubik's Cube, and for a listening task. And then we have finished our mapping protocol, and we can continue, for example, with the stimulation mapping. So now I would like to give you a brief overview of some studies that we already conducted or that were published together with the cortiQ. So of course it can be used in the operating room during a wig surgery. So here you see a case where the patient in the video is now performing a grasping task, so opening and closing the hands, and we can see that the activation converges to the 2 main electrodes here that are then confirmed, for example, with the hand motor activation in the fMRI or with the direct electrical stimulation. And we can, of course, during the surgery also move the electrodes and perform a second mapping with different locations, for example here with a picture naming task. In general, the mapping with the direct electrical stimulation with the handheld probe took 26 minutes, and the mapping with the cortiQ took an average 9 minutes. It's also possible to perform the mapping under mild sedation. So for example, with a BIS level of 70 to 90, you are not fully awake, but also not under deep anesthesia. And here it's possible, for example, to perform some kind of language mapping where you listen to different sounds and stories. So here you can see word against sound, sound against silence, word against silence, and we get significant activation for different conditions, even for this anesthesia case. And then when we, for example, look at 10 millisecond steps, then we can see that around 300 milliseconds after the stimulus presentation of a word or a sound stimulus, we can see here this positive deflection, so the strongest amplitude change after around 300 milliseconds. So all this is here. So there's the inferior temporal gyrus, mid-temporal gyrus, superior temporal gyrus, and the Sylvian-Fischer. Together with Dr. Kamada and Dr. Ogawa at the Asahikawa Medical University, we tested also how good the paradigms can be used in different conditions like the epilepsy monitoring unit and the operating room. And here there was a group of awake surgeries and epilepsy monitorings, and we could see that we almost got the same sensitivity and specificity, so there was no significant difference in the mapping results. Notably, the awake surgery cases even performed slightly better, but of course, to make a significant conclusion, a bigger cohort is necessary, but it already tells us that we can utilize the high gamma mapping in both scenarios. And there is now the biggest cortiQ study so far, with 47 cases that were mapped intraoperatively for tumor resection in Portland, in Oregon. And here the group could show that there was a reduction of the intraoperative seizure and after discharge events, but also improved overall survival rate, even though the prognostic factors were actually negative or preferable for the non-cortiQ cases and negative for the cortiQ cases. They also published a guidance how to conduct awake surgeries, including functional mapping. And in here we have the protocol of passive high gamma mapping with cortiQ, cortical stimulation, and monitoring during resection. So this should be utilized as a guidance. And then, of course, the studies in the epilepsy monitoring unit, where we can utilize the co-registered CT artifacts from the electrodes, and by that get a very good understanding about the topographical arrangement. And also we are able to nicely co-register the electrode locations with the significant fMRI voxels, so we can project them onto the electrode location and then define if an electrode is fMRI positive or not. And here we can see, for example, from fMRI mapping with SPM, we get here the significant volume. Also interestingly, next to the ear canal, we get an artifact where the fMRI is kind of not useful, because we will not see a bold response in this artifactal region. And then we can compare those fMRI positive electrode locations from visual mapping tasks. So here, phase selective electrodes have been localized with ECS, ECoG, and fMRI. And here you can see in 3 different colors. So red is for the high gamma mapping, blue is for the ECS, and green for the fMRI. We can see the topographical distribution of the phase selective electrodes or locations compared, for example, to object perception. And we can already see that only 2 patients reported phase related illusions or face perceptions during the stimulation, where the others couldn't. So sometimes it was a shape illusion or distortion of the person, but not an augmentation of the face. On the other hand, the green dots are widely spread and caused most non-confirmed locations, so the fMRI tends to be oversensitive. And the modality that was co-localized best, either with the ECS or the fMRI, was actually the ECoG. So it was a trade-off between sensitivity and specificity, but also giving us results in many cases. Of course, this is also possible with stereo-EEG. So Dr. Takeoka, for example, in the Boston Children's Hospital, already had 34 patients with sensory and motor mapping, where stereo-EEG leads nicely show high gamma activation for movement-related changes. Important is that no seizures were reported. In an extended study, Dr. Takeoka also reported that he accumulated to 47 patients, including language, motor, and visual mapping, and that 4 cases were with interesting results that were previously not expected before, but even co-localized, for example, with fMRI. So that means that the high gamma biomarker is, of course, not only a confirmation tool, but also interesting for neuroscience investigations to better understand if, for example, brain activation has been anticipated or is now a new finding. Of course, this also has to be confirmed with the signal quality always. But this is very nice that only, for example, that we can see that 95% of the cases are already good after the mapping. This is how a stereo-EEG mapping looks like in cortiQ. So here we have the raw data coming in. This is now an example from Osaka, the Kinda University. And here we now have the paradigm instructions to open and close the hand, and then we get the real-time feedback on the reconstructed brain with the virtual shafts. And we can see that there is a medial Rolandic region where we can see this task-related movement activation. So now when we look at individual timings of the mapping, so up to now we just focused mainly on the block design functional mapping, which is very simple to conduct because you only need to make sure that the patient performs sufficient good trials or enough time, a valid task to really get meaningful information. Now for the event-related mapping, we want to understand which is the most important time of a task where the activation is the strongest, and also what it tells us about the signal cascade and stimulation effects. So this is a comparison. One phenomenon is, of course, if we take all the data, then we have here these 2 significant electrodes with a moderate R² value, so to say, and then if we only chop the time before and after the movement, but not in the resting part or the transition phase, then we get, of course, a much stronger contrast and can better extract the precise information for the actual task. So here we can see when we now slice the high gamma activation into individual time frames, then we can see some periods of the task are actually silent and some are very strongly active. So here we can see also in the anatomical slice of the MRI the activation, and by that we get the high gamma dynamics, so we understand how the brain is processing the task over time. So we can also do that, for example, during a picture naming task. So here the patient says tamago, where she perceives or gets the picture presentation of the egg. And here we can see the ventral temporal activation on the visual cortex for the visual perception, and then gradually over the time the activation jumps to the frontal cortex, and we can see when she actually creates the word for saying tamago. From the Maastricht University, Maxime also processed some reading tasks, and here we could see that there is a very strong shift of the activation from the planning to the overt phase into the deeper brain sulcus parts that we can then, for example, with stereo-EEG also localize. So here there was a group study of 10 patients where she combined the electrode locations and the task data of the high gamma biomarker, and then shows us the read, plan and speak out loud phase, and we can see how nicely the activation now goes into the inner structures of the sulcus. So then we can also stimulate the high gamma activation locations, and the cortical stimulation, as I mentioned in the introduction, is a very powerful tool because it can mimic a lesion and by that guide us for the surgery. And it has been shown that the gross total resection could actually be increased and the functional deficits could be reduced by the introduction of the cortical stimulation mapping for brain surgeries. So this was a very major steps in improving the quality of the surgery, and it also allows us to more aggressively remove the tissues like a brain tumor. So of course that was also the start point to compare and the benchmark to compare with. So for example, the group of Eric Luckert showed how good the high gamma biomarker overlaps with the electrical stimulation results. And in general, we can say that with the high gamma mapping guidance, we can reduce the stimulation effort by 40%. So that is also, of course, in line with the findings from the group in Portland, where they had reduced after discharges and seizure events during the surgery. So when we then utilize the high gamma marker as a kind of guidance, then we can still achieve a 92% stimulation pattern with 40% reduced stimulation effort. And how we can improve the stimulation procedure in general. So for example, when you imagine that you have like 100 or even more electrodes that you have to connect, each electrode has to be connected individually, either to the amplifier or the stimulator for the stimulation and the high gamma mapping. So we really need a switching unit that does that automatically to reduce the number of errors, because you have to imagine the whole mapping routine involves many people and everything starts with the electrode connection. If one electrode is connected wrongly, then all other subsequent steps will be wrong and misleading. So this is a simple but very important step, and if we can make that more robust and faster, this is a very strong benefit. And with the switching unit here, we can achieve that. So we have a programmable way to choose the stimulation channels. We can programmatically route the ground electrode. So for example, if some of the signals are, or if basically all the signals look bad, that is an indicator that the ground electrode has a high impedance or is not nicely attached. Then we can simply, inside the software, change the ground electrode to a spot that has a low impedance or similar characteristics as the recording electrodes, and then we can improve the signal quality overall. And also it's possible with the switching unit to perform an impedance screening, so you can learn how the spectrum, the impedance spectrum looks like for different frequencies. So now we can load our high gamma activation maps that we, for example, got from the picture naming task. And then we can route from the switching unit to the stimulator and stimulate by interactively localize or selecting the stimulation electrodes on the brain map. Stimulate here with the stimulation artifact, assign a symptom and functional category, and by that complete our map. And of course, afterwards, it's also possible to understand which time is the best time that explains us our stimulation symptom. So we can further learn when in the brain the stimulation actually causes an effect. So for example, here the patient is looking again at the tamago, and when we stimulate, then at the time of the stimulation she cannot respond and she is hesitating to say tamago afterwards. So there is a clear stimulation effect. So when we do that without stimulation, we have the high gamma activation, and we can nicely hear that she is without any problem and quickly responding. But for the stimulation, first of all, she has transient aphasia or speech arrest, and later on she is hesitating. And we tested this in a neuromodulation study to better understand the stimulation effect. So Dr. Kamada later on will tell us more about this study. We can also see similarities between the high gamma biomarker and the stimulation effect for the visual cortex. So in this study published in PNES together with the MIT, with Nancy Kenwisher and also with Göran Schalk, we found very strong phase selective and color selective regions on the fusiform gyrus and also more on the posterior visual cortex. So if we come from posterior to anterior, we come from the low visualization cortex to the higher visual categories. So here we have the color perception or color understanding, and here the phase selective regions. And we can see when we go now to a location here that, for example, when looking at the face, this location, the high gamma biomarker jumps, but all the other stimulus didn't cause any change in this location. Where if we go, for example, to this color preferred site, then we can see that all the categories have a very strong activation independent of the category. So now when we stimulate with this arch into a phase selective region, you can see here the stimulation artifact. You can see here the after discharges. So now we are with 8 milliamperes for this electrode size at the maximum stimulation current that we can utilize. Otherwise, we are at the risk of inducing a seizure with the stimulation.
One more time.
Tokugawa finally turned into an anime character, and the other objects also showed a virtual face on the surface. Here you can already see that it's very difficult to conduct a precise stimulation mapping to really get the understanding of the symptom and the perception of the patient. So with the high gamma biomarker, we can immediately see that when we present different visual categories, which are face selective or which are color preferring sites. So with the stimulation mapping, of course, this is also possible, but it really requires that the patient contributes. And that is also one reason why, for example, in the study for the visual mapping before, the ECS was only visible or achieving results in 2 out of 5 patients. Christoph mentioned that in the talk before, it's even possible to look at high gamma changes or broadband activation up to 800 Hertz. So in the study from Nuri in Cefirat, they showed how the ultra high gamma frequency range further contributes to precisely localized task-related changes. So here with the data glove, when a closing movement was achieved, we can see that a signal usually is around 200 microvolts. If we go into gamma regions around 60 to like 200 Hertz, then we get the 50 microvolts maximum amplitude. And here we are at 8 microvolts. But you can still see how that looks like in the filtered raw signal. So that is still visible. And then we can see there are some electrical stimulation locations, and we can, with the ultra high frequency band, narrow that down to the stimulation target. And that is possible of the high SNR of the amplifier. So we have 86 nanovolts resolution with the 24-bit ADC and the 340 millivolts input range. Because of the high oversampling rate, even the high frequencies are still with a very strong signal-to-noise ratio. All right, and then finally we have the overview about the use cases and the status of our device. So the cortiQ for high gamma mapping and stimulation mapping with the switching unit, impedance check and EEG recording is now CE certified under MDR, and also the green modalities are already FDA cleared, and now we are working on the clearance with the final step, the channel switching, and then we have the complete cortiQ, including the stimulation and the high gamma mapping, also FDA cleared. And on top of that, you can utilize the high gamma mapping system and the stimulation system as a closed loop neuromodulation platform. So with the research software, for example, in MATLAB and Simulink, it's also possible to sense and stimulate for biomarkers, for example, for TBS or RNS closed loop applications, or for other indications like, for example, psychiatric disorders and so on. And of course, it's also possible to record epilepsy biomarkers and support clinical research in epilepsy or CCEP connectivity studies. Okay, so thank you very much. I hope you got an idea how to run high gamma mapping, and yeah, happy to see that in the future.
Thank you very much, Kapi. We have a couple of questions. Can you please explain why and when the electrical stimuli are delivered into the brain area through cortiQ?
Sorry, when?
When and where?
So basically, the high gamma mapping is done first as a screening, and then we can select the stimulation locations based on the activation map. So we can stack previous results and then make a decision which are our stimulation targets to minimize the stimulation burden. And so chronically or chronologically from the epilepsy monitoring. So first you conduct the monitoring, And the high gamma mapping can already be done in parallel because it's no risk of inducing a seizure. And after that, you perform a stimulation mapping. And inside the operating room, also first you conduct the high gamma mapping when the patient is awake, and then on the grids or with the handheld pen, you can continue with the stimulation mapping.
Another one, what's the reason that most of the ECoG articles are written as case studies?
Well, of course, ethically you have to be careful because every single case requires a brain surgery. And it's not an indication or a use case to simply, for a study, implant persons. So it's not like an fMRI or EEG study where you can make an easy study plan and choose and recruit subjects. So you really always need a patient, and this patient has to agree to contribute, and also you need a complete team that enables this research and this study. So if you get a study with already 50 patients, this is a very big cohort already for these scenarios.
Sonic actually wants to know a couple of things. So he's asking, during the surgical procedure, there will be some local anesthesia. Maybe you can comment on that, local anesthesia. How is it done?
Well, you have to discriminate between anesthesia for general anesthesia surgery and awake surgery. So most of the stimulation mappings are actually done under awake surgery. So there's scenarios where you can, on the complete general anesthesia, do, for example, motor evoked potentials or median nerve stimulation, somatosensory evoked potentials that show you the motor cortex and the corticospinal tract. But if you come to language mapping, you need to wake up the patient during the surgery. So of course, when the patient is awake, they will get painkillers and make sure that there is like no adverse event during the awake phase. If it comes to like anesthesia mapping with a BIS level, then simply the anesthetic drug dosage will be reduced.
And he's also asking, because of the anesthesia, isn't it this theta and delta waves are influenced? So how do you consider that during the high gamma mapping?
So there are, of course, effects of the anesthesia. So it's recommended to use propofol for the electrocorticographic recording during the surgery. But yeah, from the studies that are already out, we know that the high gamma biomarker also works during awake surgeries.
Laila wants to know, can you do ECoG for multiple brain regions similar to EEG?
So the limiting factor is only the craniotomy. So you can move electrode grids under the dura on the cortex, and you have to be careful that you don't damage a vessel. And of course, the size of the craniotomy, which is a few centimeters, has to be able to make a hole where the electrode grid fits inside. So it really depends on the surgeon how many grids on how many locations can be implanted.
But this is of course a big advantage of EEG, so you can always put as many electrodes on the human scalp as you like. For ECoG, it's guided by the illness, so where the tumor is located, where the seizure is located, and you cannot just put in more electrodes in. So like mentioned before, there are many applications for ECoG, but there are also many applications for EEG. Thank you very much, Kapi. This was very nice.
Thank you.